So the incidence of stomach cancer is very high in Japan because of combination of factors. The number one is Helicobacter pylori infection. The second is dietary factors like high salt diet, taking smoked foods, and also taking less of vegetables and fruits. And third is because of the aging population in Japan. The most important of this is Helicobacter pylori infection, which is related to 90% of the cancers, gastric cancers, known cardia, and it is type 1 carcinogen as per WHO. So it causes carcinogenesis by multiple pathways. The important is that it progress the chorea cascade, which is related to the carcinogenesis in stomach. It causes chronic gastritis in all patients, which further progresses to gastric atrophy, intestinal metaplasia, dysplasia, and then gastric cancer. So the pathway is very important, and the first step in this pathway is regulated by Helicobacter pylori infection. The second is that it also causes pangastritis that causes reduction in the production of acid in the stomach. When the production of acid in the stomach reduces, there is more infection by other bacteria, which results in methylation pathways, also resulting in conversion of nitrates to nitrites in the food, which are again carcinogenic. So the Helicobacter pylori is related to 98% of the gastric cancers in Japan, and as the incidence of Helicobacter pylori infection is decreasing, the gastric cancer risk is also now on the decreasing trend, but it is still the third most common cancer and also the fifth most common cancer causing mortality in Japan. So the mode of transmission is still not very clear, but it is expected that the most common mode of transmission is oral route or fecal-oral route. So the water, if contaminated with Helicobacter pylori, can be an important source of infection. And with the improvement in sanitation and disinfection practices now being followed in Japan and worldwide, the incidence is now on the decreasing trend. And in 99% of the cases, the infection is acquired during childhood, and if not treated, it persists lifelong. So once we acquire this infection, which is mostly in childhood, all the patients will develop chronic gastritis, but 90% of these patients will remain asymptomatic throughout their lifetime, and only 10% will develop the symptoms like peptic ulcer disease, which include gastric ulcers, duodenal ulcers. Patient can develop gastric cancer. The risk of developing gastric cancer is 5% over 10 years. Also, other manifestations include idiopathic thrombocytopenic purpura, gastric malt lymphoma, and also it can lead to upper GI bleed related to peptic ulcer disease. Which patients will develop what manifestations? It depends upon the virulence factors of Helicobacter pylori, genetic factors of the host, and environmental factors. So all patients will not develop symptoms, only 10% will develop manifestations. Once we plan to diagnose Helicobacter pylori infection, there are two methods to diagnose it. First is non-invasive methods, and the second is invasive methods, which include endoscopy. In non-invasive methods, the gold standard is urea breath test, which includes giving radioisotope carbon along with urea, which is converted into carbon dioxide and ammonia, and this carbon dioxide is measured by urea breath analyzer. The second is stool antigen test, and the third is serological testing. So serological testing includes measuring antibodies in the blood of the patient. This should not be done post-eradication, because once it becomes positive, then we are not sure whether it is positive due to active infection or due to past infection. So then moving on to invasive test, there are endoscopy-based tests, which includes rapid urease test on the biopsy sample. The second is histopathology test, when we stain the tissue with specific dyes to see Helicobacter pylori in the tissue. And the third is PCR-based test, which is molecular-based testing. It is the most sensitive and specific method, but because of the non-availability of molecular-based testing, it is not widely used. But these are three major invasive methods by which we can detect Helicobacter pylori. So the treatment of Helicobacter pylori needs multiple antibiotics. The gold standard across various international guidelines is to use bismuth quadruple therapy, but in Japan bismuth is not available. So still in Japan, guidelines recommend using PPI or vonoprazan based triple therapy, which includes a PPI, which is pantoprazole, esomeprazole, or rabeprazole, as the clarithromycin resistance is increasing worldwide, which is more than 15% in most of the regions of the world. The shift in treatment is now to bismuth-based quadruple therapies, which can overcome the resistance of clarithromycin as well as metronidazole when used as a combination. So Helicobacter pylori is a very peculiar organism to survive even in the acidic environment of stomach, because Helicobacter pylori has abundant urease enzyme. It converts urea into ammonia and carbon dioxide, and this ammonia is a alkaline substance which creates a protective environment around this bacteria, which prevents its killing from the stomach acid. Once it gets time from this protective environment, it goes deep into the mucus layer of the stomach, where the pH is higher than the acidic stomach pH. So it survives in this mucus layer by getting attached to the epithelial layer by expressing adhesing protein, and also it can convert to biofilm formation or cocoid formation, which again protects it from the acidic environment of the stomach.